Hello, everyone. Thank you for allowing us to present our paper in this conference. My name is Dr. Ahmad Albosaily. I am a consultant head and neck, Otorhinolaryngology, head and neck surgery, and fellow of head and neck oncological surgery at King Saud University in Riyadh, Saudi Arabia. I would like to present our paper, which studied the factors associated with facial weakness following parotidectomies for benign parotid diseases. So the usual goal of parotidectomy is to completely remove the parotid disease while maximally preserving the facial nerve function. The reported facial nerve weakness ranges from 9 to 65% as a temporary facial weakness. The permanent weakness is a lot less common, ranging from 0 to 8% on different reports. Facial weakness is the most common and the most concerning complication of parotid surgery. Malignancy is well established as a risk factor for having facial nerve weakness after parotidectomy. However, other factors are still controversial and studied, and they can be also studied on benign diseases to look for the other factors related to patient or surgery. So the objective of our study was to study the rate and frequency of facial nerve weakness in our population, the prognosis of facial nerve weakness, and try to analyze the risk factors for facial nerve weakness after benign disease, after parotidectomy for benign disease. So after obtaining the IRB approval, we conducted a retrospective study of the medical records in 2 centers in King Abdulaziz University Hospital and King Fahd Medical City. The study period is from 2006 until 2018. We excluded cases of parotid malignancies, patients who already had preoperative facial nerve weakness, either from disease or from previous surgeries, and patients who had intended facial nerve resection. The variables we studied were divided into 3 categories: patient-related variables like age, gender, and disease diagnosis like diabetes, being smoker, and if there is any history of previous surgery. Disease-related variables were location, the final histological diagnosis, and the presence of ceridinitis in final histology. And surgery-related variables like the side, the direction of facial nerve dissection, whether this nerve was dissected antegrade or retrograde, the extent of surgery and how much volume of the parotid was excised, the duration of surgery, and the use of intraoperative facial nerve monitoring. We defined the extent of surgery according to the literature, into superficial parotidectomy. This is when the entire superficial lobe is removed with formal facial nerve dissection. And partial superficial parotidectomy is when formal dissection of the nerve is done. However, only part of the superficial lobe is removed. And when the whole gland, both superficial and the parotid lobes were removed, we define this as total parotidectomy. Extracapsular dissection was defined as the removal of a disease with a cuff of normal tissue surrounding that disease. However, there is no prior formal facial nerve dissection that is identifying the facial nerve main trunk and branches before removal of the disease. Inoculation is the removal of tumor only without surrounding tissue and without facial nerve dissection. We defined facial nerve weakness as of upper division if it's affecting the eyebrow elevation or eye closure, and lower division if it's affecting mouth closure or lip symmetry. Temporary facial nerve weakness was defined as weakness that resolved completely upon follow-up, and when the patient did not regain facial nerve movement within 12 months, it was considered permanent. We graded the facial nerve weakness according to the House-Brackman grading scale, which is the main scale used in our centers and documentation. The statistical analysis, we conducted it using SPSS version 23. We had descriptive statistics in terms of mean and standard deviation, frequencies and percentages, and median and ranges as appropriate depending on the data distribution. We conducted bivariate analysis using the t-test, Mann-Whitney U test, or chi-square test, depending on the variables being analyzed. And the multivariate analysis, we use the multiple logistic regression for factors that appear to be significant on the bivariate analysis. P-values of less than 0.05 were considered statistically significant. So results, we had 191 parotidectomies, which was performed on 183 patients. Most of our patients were in the age range of 18 to 60 years. We had around 10 patients in the pediatric age group and 13 patients who were above 60. The gender distribution was almost equal between male and female. We had 32% of our patients who were active smokers at the time of surgery. And we had 15% diabetics. The surgery was primary in the vast majority of the patient, in 94%. Revision surgery was done in around only 6% of patients. Intraoperative facial nerve monitoring was used in around 21% of our patients. The extent of surgery, we had the most common surgery performed was superficial parotidectomy, which was followed by total parotidectomy. We had very few numbers of extracapsular dissection, which were around 8 patients, that constituted around 4%. Most of the facial nerves were dissected in antegrade fashion, around 80%. We only had around 17% of parotidectomies were done retrograde. Postoperative facial weakness that was recorded in our patients happened in 61 patients, around 32% of the cases. Most of them were temporary in 46 cases, constituted around 24% of, this is the overall percentage of all patients, 24%. We had 6 cases of permanent weaknesses, which is inadvertent because we excluded patients who had advertent or sacrifice of the nerve. So 3% of the cases had permanent facial nerve weakness, whether this is most commonly in the as branches. 9 patients did not have enough short follow-up to determine whether they had temporary or permanent. The duration of follow-up, the median was around 10 months, but ranged from 0 to 125 months. So analysis of the facial weakness subgroups, we had a total of 61 patients. Most of them were around 60% had weakness in the lower division, followed by complete weakness, which includes both upper and lower division. However, very few of them had isolated upper division weakness. 46 patients were recorded as temporary weakness, and also most of them were in the lower division. Very few, only 4 patients had all the branches involved. In temporary weakness, it's here important to notice that most patients, around 84% of patients, had a grade of weakness 2 to 3 postoperatively. That is temporary weakness. We had 6 cases of permanent weakness, and also around 80% of them had weakness from grade 4 to 6. So that is different from temporary weakness in the grade. That's the postoperative grade. the immediate postoperative facial weakness grading. Patients with temporary facial weakness, this is the timeline of resolution of the temporary facial weakness. Most patients, they around 90%, they resolved within 6 months. All our patients recorded the complete resolution of the facial weakness within 10 months, and around a quarter of them within 1 month. It took half of them to resolve completely within 3 months, and 90% of them resolved within 90 months. The bivariate analysis to determine the significant associations between different patient and surgery-related and disease-related variables and the occurrence of the incidence of facial weakness showed that temporary weakness was associated significantly with total parotidectomy, with the extent of surgery of total parotidectomy, but not less than total parotidectomy, and with extent of excision, like specimen volume of more than 60 cubic centimeters. Permanent weakness on the bivariate analysis was significantly associated with revision surgery, as well as extent of surgery of total parotidectomy. So we took these factors and we analyzed them using the multiple logistic regression to go for multivariate analysis. Other factors like age, gender, the diagnosis of diabetes, smoking, involvement of deep lobe, did not have any associations with facial weakness on bivariate analysis. Also, the use of intraoperative facial nerve monitoring did not seem to have any association with the facial weakness, whether positive or negative. And there was no difference in the incidence or the rate of facial nerve weakness between patients who had either antegrade or retrograde facial nerve dissection. The multivariate analysis was conducted for those factors that appeared to be significantly associated on bivariate analysis to identify the risk factors for weaknesses. For temporary weakness, we identified 2 risk factors. These are the total parotidectomy with an odds ratio of 3 and specimen volume of more than 60 with an odds ratio of 2.2. For permanent weakness, only revision surgery was a risk factor in our study for permanent weakness with an odds ratio of 17. So in conclusion, 32% of our patients had facial nerve weakness following parotidectomy, of course. Most of them were temporary weakness. We only had 3% of temporary weakness. And we found that a weakness grade, immediate postoperative weakness grade greater than House-Brackman 3, that is 4 or 5 or 6, is a poor prognostic factor for recovery. This has been also found in one previous study. We also found that the extent of surgery is an important predictor, evident by total parotidectomy being a risk factor for temporary weakness. And among the patient's factors, only previous parotid surgery was a significant risk factor. And we found that the revision being, the surgery being revision significantly increased the risk of having permanent weakness with an odds ratio of 17. What are the weaknesses in our study? First, it's retrospective, so it's prone to reporting and subjective bias. It's the data were collected on patients from tertiary care centers, so selection bias should be considered. And the third one is the potential for type 2 error. That is, we had an underpowered sample size. We had 191 parotidectomies. And in some variables, we had small numbers like extracapsular dissection. We had only 8 cases. An example of that would be if we had more cases of extracapsular dissection, we might have found a protective effect that there is an association or decreased risk of temporary weakness without facial nerve dissection, like in other studies. However, because of the number, it was smaller than previous studies. In this type of surgery, we could not elicit this association. I'd like to thank you again for allowing us to present our paper, and if you have any questions, I'll be happy